talk about decoupled data models and how they can actually speed digital transformation. The challenge with healthcare is that as healthcare started to race to digital, albeit very late in the game, we created a very fragmented user experience. So consumers now have portals and passwords for every doctor, every hospital, every lab, every radiologist, every pharmacy, all of their employer-sponsored health and wellness programs, which average 15 to 21 different disparate programs, and HSAs, FSAs, and let's not forget the now more than 300,000 digital health applications that sit on the cloud. What compounds this and makes it worse is that consumers and their families typically have one healthcare decision maker in their family. 86% of the time, that's a female. Caregiving to children, spouses, no offense to you gentlemen in the room, but you often are very late to receive care. This is proven from a data perspective. You're often very sick by the time you seek it, and therefore more expensive and costly. So we know that our job sometimes is to nag you into that preventative care. But also now, more importantly, to our aging parents who are aging in homes thanks to technology. And sometimes, like in times of COVID, when we can't be in front of them, being able to connect to their healthcare records and recommendations to pick up the phone and call is becoming quite important, or even join into those telemedicine conversations. All healthcare stakeholders have a different view of an individual, whether you are whether you are a payer or a provider, whether you are a pharmacy, a wearable, a device, a sensor, social determinants, and even preferences and likelihoods about consumers. So each stakeholder in healthcare has a very different view of the world and of an individual. It's why we've always joked in the healthcare space that we're constantly chasing data, not actual gaps in care. So it's important from a data liberation perspective that consumers have the right not only to collect and aggregate their data, but to share that information back with people who add value into their healthcare journeys. Interoperability is here. We've been talking about it for the last couple of days. We no longer need to talk about whether or not information blocking or interoperability will become rule. We need to talk about how they can be leveraged to add value. The conversation needs to change between how do I become compliant from a regulatory perspective with my open APIs, and how do I actually help those APIs create use and value from a delivery system perspective. Interoperability allows us to do something for the first time that's never been done before in healthcare. Hyper-personalization and omnichannel communication to an N of 1. Technology has advanced pretty far down the pathway, and I would argue that healthcare is still sitting back in the 1980s with the fax machine still being a very widely used tool. It's actually not even funny anymore that we still have to make that reference or that joke. But the reality is that with data science and personalization, the evidence-based medicine guidelines, and finally the liberation free of data, with consumer consent, we can now use omnichannel communications to communicate with patients in the way that I was the only one saying it, that the time for picking up the phone to make a doctor's appointment is behind us. Consumers want to mobile and digital schedule their appointments. They want to be in charge. It should be easy to, just like an airline, change your ticket, cancel, reschedule. We have testimonials from users that talk about the fact that they can order a pizza and watch it go into the oven, out of the oven, in down the street, to a front door with a doorbell ring, and we still have loyalty and engagement for consumers. They absolutely want to know why you are messaging them, which brings a new era of consent to the fold. Consent not only to collect and aggregate records, consent to share that data back, consent to opt out of portions of HIPAA in order to personalize communications to let consumers know why you're reaching out. A text message that says, Dr. Smith has new lab results for you, please click here, is a lot more personal than you have an update in your portal. Portalitis is a disease that I think we can eradicate in this current time frame. I started this company because I have a child with an autoimmune condition. That child has 17 provider portals. None of them are accurate, none of them talk to each other, and worse, now that some of them are starting to connect, they're proliferating errors across multiple different health systems that quite frankly put her life at risk. She had a near fatal incident because 2 EMR systems couldn't communicate with one another. Personalization is everything. We are very paternalistic and one-size-fits-all in healthcare, not because we intentionally do so, but because we hide behind regulations like HIPAA. Consumers actually have the power to change that, and we need to leverage that because they're asking for more personalization. They're asking to get proactive and upstream, and for someone to have their back, because ultimately what consumers want is 2 things. Be there for me when I need you, and tell me when there's something I need to do. And our current healthcare delivery system has a lot of friction baked into both of those. So we believe it's time to give consumers and their families something that they've never seen: themselves. Access and transparency to all of their data with insights aligned to evidence-based medicine in order to help them understand the value of when it's time to manage someone who I caregive to myself, to my spouse, to my nurse neighbor, or anyone who I consent to share that information to. But this allows us to create workflows that remove the friction from the system and start to offer choice. So when we think about things like value-based measures, that health systems, payers, even employers managing risk because they're aligned to having to pay for healthcare services, that we need to get a little bit upstream and get more proactive. So we want to be able to say things like, hey, happy birthday, it's time to get that colorectal cancer screening. Now, we would never actually message anybody on their birthday for a colorectal cancer screen, but it is important that they know that they are eligible, they are due, and that they have choices. Consumers largely today do not feel like they have choice in their care. They believe that when they go to the doctor is going to tell them what to do, and they're going to sometimes follow suit, or they're going to abandon if they don't like what the doctor has to say. So we believe that choice, much like Amazon, gives us choice in how we shop and what colors and sizes and value that we want to bring, that healthcare needs to do the same thing. So when we get that educational message that someone is due for a colorectal cancer screening, wouldn't it be great if we had an option? Would you like to mobile schedule an appointment with your doctor to come in for a colonoscopy? Or would you like me to send you an FDA-approved toilet water test to your home that you can drop in the mail and we can set you up for a telehealth visit? Or I see you're picking up your medications from the pharmacy on Friday. The pharmacist is going to give you a Cologuard, show you how to use it, and you can drop it back off at the pharmacy. When you give consumers social contracts and trust that you can fit into their lives and that you value convenience and their busy lives over just what a physician has in terms of their schedule, they're going to feel more appreciated, more loyal, and they're going to follow through with their actions more frequently. In comes the concept of the decoupled data model. For far too long in healthcare, we have said that our system of record or our source of truth has been the EMR, or a payer system, or an employer benefits system. Depending on who the stakeholder is, we have a different source of truth. And the reality is that no stakeholder has a consistent source of truth because only the consumer can actually tell you what is the reality within their healthcare. Now that we have opened up FHIR APIs, giving consumers access to their records, we can start to see errors. Why I believe FHIR needs to become bidirectionally very quickly. I have a 19-year-old daughter who, according to one of the top academic medical institutions in the country, has an enlarged prostate. It is an absolute medical miracle. And quite frankly, it was a miscode on an infection that was an inflammation of her current autoimmune condition. But I assure you she does not have an enlarged prostate or a prostate at all, for that matter. The decoupled data model allows you to think a little bit differently about how we look at not only interoperability, which we've talked about here today, but aggregation of solutions, because it is going to take all kinds of solution providers to come together to create an ideal experience for consumers and their families, knowing that each one is different. The decoupled data model means that you can bring the outside data in through interoperability. You can aggregate it with all of your internal core systems and the data that is accessible. You can put it on a FHIR native platform and you can API out everything. By doing that, it allows you to start to use current technology, not only for omni-channel communications, but to create a configurable front end that could actually be delivered differently depending on the digital persona of the person that you're talking to. So the front end screen can actually change based on the user properties that we can now collect. But the idea is that you actually build your applications and systems around the user and their families, not around the core system that you've implemented. So instead of thinking about having multiple systems talk to each other, think about having your systems be re-architected against the current streamed and real-time accurate data that you've put at the center of all of your development moving forward. And that is the actual human that you are serving. Bidirectional integration is key. You cannot go into healthcare and tell people that they can't use their core systems. So making sure that you can get information to the point of record that's going to matter in their care. We do know that consumers trust their doctors. They will absolutely say, yes, I want my doctor to have all of the information from a health perspective at the point of care. And we can then, every time there's an update, push that information into the EMR. The EMR is a billing system. It is a system of record for point of care transactions. It is not a digital strategy. I love the thumbs up back there. So The idea is bidirectionality. When you have this decoupled data model, that's where your data science sits. That's where you get better, smarter, faster. That's where your application development happens. That's where you spin out your IP. That's where you aggregate and integrate solution partners. Keep in mind, the only thing in healthcare is change. We are going to change technologies. We are going to change solution providers. If we had this conference 20 years ago, the solution providers on the floor would look very different than they do today. And that means that trusted stakeholders, whether you are the payer, the provider, the pharmacy, or the employer, need to have that single pane of glass to give consumers all of their information in one place, but still allow it to change on the back end without having to re-engage the user. Because the number one thing consumers do not want to hear is, I need you to go download that app, and that app, and then that app, and then this one over here, and then that one you said you might like, and oh, this one's a new one because we see you've tipped over the weight limit. We have portalitis and app fatigue, and consumers really simply don't know where to turn. So personalized recommendations based on their data, their preferences, and their evidence-based guidelines can actually be recommended by giving consumers choice. We're not the only ones talking about this. Ernst & Young, Deloitte, and every other large consulting firm has published white papers talking about decentralization. The key theme that you're going to see is radically interoperable data and open, secure platforms. We all know that we can't go into how we've been buying healthcare services for our stakeholders and the populations we serve the way we have before. First it's an RFI, then it's an RFP. Let's assume a budget came before that, or we're scrappily fighting for one because we think that there's a need. Then we go through procurement, then we go through onboarding, then we go through security, and then we have to do last mile marketing out to the populations we serve. Being able to create open data source platforms actually allows you to let partners onboard themselves to your model so they don't become a line item in the IT roadmap. How many times have we heard that, oh yeah, we'll get to you in 3 years, because we absolutely don't have the time or capacity to continue to integrate new solutions. So we're not the only one talking about this. This is particularly important. We provided some useful links, but effectively what you're going to see is that all of these decoupled data models put the data layer and the consumer directly at the center. This allows you to, again, put the consumer at the center, integrate your core internal systems, apply your data science, and then put together all of the different things that you need to do for users while technology continues to advance. The APIs out are your speed. You can get ahead of fire. No offense to all my fire people in the room. Payer and provider data is not the only data that consumers need and or care about in their healthcare. Social determinants is very important, making sure that we can collect pharmacy and lab, and preferences and likelihoods and goals and outcomes and concerns of an individual need to be taken into consideration. So being able to do this not only accelerates parity across your applications, it allows you to connect with health systems to payers, payers to providers, providers to pharmacies, but also adopt new business models very quickly, because you have the data of the population that you serve and you can deliver that out very quickly and monitor the progress of the data. Health systems are actually already doing this work, and they are receiving very good outcomes. So not only is the consumer satisfaction sky high, between 94 and 98%, where people like the digital conversion and transformation strategy, but we're seeing that by removing some of the barriers, like things like OAuth, adding guest access, where you actually don't have to know who the human is before an appointment is made. You can let them decide, just like in retail, that they want to make a purchase, they want to buy, they want to have an appointment with you. Get that login and password information on the back end. Don't be so afraid of authentication on the front end, because you're simply opening up the ability for someone to buy a service. Having consumers be in charge of this information actually allows them to show up. They feel in control of their appointments, their cancellations. We've been able to take health system no-show rates down to 2% with an industry average of about 18 to 24%. Those are real dollars. That is real loyalty. People are going to show up. But it means getting out of the portal and advancing capabilities that portals don't offer. If your doctor can't see you for the next 7 weeks, 70% of you are going to abandon. Let's tell you who the next available doctor is, or if there's a telemedicine visit that can actually see you today. And that's stacked aggregation. But most importantly, aligning people to gap in care closure. We talk about gaps in care, but the reality is we're aligning humans to evidence-based medicine. By aligning them to evidence-based medicine, getting them upstream, we have proven over time through multiple national studies that not only can we help keep people healthier, avoid preventable chronic disease, but we can actually elongate life. And that's why we all sit here in these conferences every day. trying to help people lead healthier lives. And no matter how many slogans there are, if we can't personalize a communication to help make an individual and the people they care for healthier so that they are not dying poor and sick, which is the funnel problem we have in the US population today, we're not going to get there. The only way to bring down costs is actually to help make people healthier and get upstream. We can talk about pricing all day long, but the reality is we need people to be healthier. And that means we have to fit into their lives when, where, and how they want. Happy to answer any questions, and hope you all got another cocktail. Woo. And thank you for being here so late in the day. Yes.
I'd like to ask a question.
Fire away.
The fundamental issue that we see from this concept of interoperability is understanding the authoritative source.
Yep.
Helping organizations understand where that authoritative source is and avoid, forgive the expression, store and flow. We have way too much data duplication. We have way too much
So we want to avoid store and forward. We want to help. The EHR shouldn't be, by nature, the exclusive patient authoritative source, because no EHR services the entire patient's health concerns. They're not part of the care continuum.
Agreed.
They're a component, but they're not the care continuum.
That's right.
And some people will say the EHR is the longitudinal record. No, it's not. The EHR is designed and sold so that some administrator can bill for the care. It's an episode of care. And there's a very large EHR implementation, somewhere around $20 billion, that's actually learning that. Oh my God, an EHR is not longitudinal care. That's right. So question to you, how responsive are you finding these EHRs? We know what the EHRs want, and they don't want this. They don't want you. Like, this is not good for them. How do you help the industry understand what becomes the authoritative data source? Because you are disrupting what the authoritative data source is. How are you handling that?
Oh, very carefully, and with a very nagging voice that is consistent. So the question is, it's disruptive, largely to portals. EHRs in the very beginning absolutely were trying to tether individuals to portals. Going to the provider community and suggesting that you absolutely have to have a patient portal so that you can be compliant with MIPS and MACRA and meaningful use, when in fact those rules and regulations don't require you to have a portal at all. It can be through a front-end mobile and digital application. It absolutely does not have to be tethered to a portal. In fact, some of the earlier EMRs, and not to be named very large ones, went to our customers after they sold us and requested access to APIs in their sandbox, that they would go and they would say, oh, no, you need to use this other implementation that we like to call data tiles, which is nothing short of, I'm going to drop you back into the patient portal. So it was a way of saying you can create a new digital front door, digital transformation platform, care continuum platform, whatever you want to call it. You can create that customer. However, you need to, if you want to drop people into scheduling, messaging, RX refill, all of the different APIs of EMRs, you're going to simply drop people in to their patient portal and require them to log in. And in fact, they put up barriers that are actually, they look, excuse me, I'm not even going to use French, but murder scenes. Basically, beware of this app. We don't know them. They're not trusted. They're going to have access to your data. Are you sure? Basically, don't do this, right? And so they absolutely railed against. But what I think they learned, and we've seen this pivot happen in the last year, is that as everyone's moving more towards the cloud, the concept of the proprietary API came out. So yes, there are public-facing APIs on the patient right of access, but the reality is the war-to-be one is on access APIs, because data is table stakes to be in digital health, to personally know someone. The access APIs around scheduling and talking to my doctor and things, that's the war-to-be one. Well, what they realized is that cloud providers make their money on API transactions. So how many times can they make you make a call in order to successfully book an appointment, check eligibility, cancel, reschedule, and they make transaction fees on every one of those. So they've now modeled that, okay, maybe we'll give up on the portal because it's probably not where people are going to go long term because they want individuality. And health systems across the country will tell you, we can't wait for Epic, Cerner, Athena, Allscripts, fill in the dots. We can't wait for them to develop the thing we need most.
Does that mean that you're building proprietary API responses? Are you interacting with proprietary APIs?
We are absolutely interacting with proprietary APIs, and there are yeah, we're hoping they'll get better over time. But what we realize is that those APIs are very immature, much like a lot of interoperability is today. There's a lot more, we're on first base. We've got a long way to go. But the reality is that those proprietary APIs still allow us to have control of the consumer experience. So again, a portal today simply says, hey, I'm going to make a call to this doctor. Here's their availability of scheduling. It's not going to handle the situation when that doctor's not available for 14 weeks because they want to hold their schedule to still book when people call, or they want to play golf on Monday, Wednesday, and Friday. So the reality is that it's not going to meet the consumer demand, and so that logic layer of data helps us to understand and start to pull out which consumers care about convenience and lack loyalty to a doctor. If it's convenience they care about, why not surface the today option first? You're more likely to keep people in the network, avoid leakage, and be able to keep them in. And as we see more and more, both insurance carriers and health systems stack their provider directories to the providers that offer the highest quality at the lowest cost because they're at risk, it becomes more important that we start to surface those doctors first as well. So the whole concept of how we navigate indirect care is changing.
Yes. I'll let others ask questions. I have more. I'll let others ask. And if there's nobody, I'll ask another caller.
Does anyone else have a question? Yes. Do it. Of course you are.
That was kind of a joke because I'm sure Mario's going to ask some questions.
About testing.
I do have a question, and I'll be quick. You can jump on this, Paul. You've got a huge uphill battle, right?
Always.
What do you envision as the biggest obstacles for your uphill battle? Is it the EMR?
No, it's not the EMR. I think the EMR figured out how they can absolutely replace their revenue. And I think, quite frankly, them not having to manage and maintain portals and complaints from other customers will eventually be a relief. I really do. I don't think that that's the hill to die on. I think healthcare in and of itself is an uphill battle. I think that there are two things that keep me up at night that I'm really afraid of. One is culture change. You cannot have successful digital transformation if you cannot successfully change the culture of an organization. Healthcare was built on waterfall, risk mitigation. They're not as innovative to get MVP products to market that are, maybe not everything everyone wants them to be. We really don't do a lot of UX, UI, design, research, testing, and the things that consumer products were built on. So that culture change is really important, and it's really hard to set up governance because a lot of organizations still create decisions based on committee. And there's a lot of people in the committee when you're trying to do something that touches an end user of the population. I think the second thing that keeps me up at night is, quite frankly, the fear that we've been talking about here all week, which is there will be bad actor apps. There just will be. There's bad actor providers. There's bad actor insurance companies. There's bad actors in every part of healthcare. There's a reason that the mafia is in healthcare and not in trash, right? It's easier with lower penalties. So the reality is there's going to be bad apps. And if those bad apps emerge before the good ones take a foothold and actually showcase the best terms of service privacy policies, the informed consent, the commitments to not share and sell data, and the things to build trust, there's an opportunity for the press, social media, and the cancel culture to actually take over what we've been trying to fight for and build for the last 10 years. So my fear is that if we don't build some of these good application standards up so that they are more prevalent and known in the market before the bad actors come in, and there's penalties, fines, and fees, that it really breaks down a lot of really hard work that we've been pushing on. You're up, Paul.
Would you mind scrolling back a few slides, and I'm not sure I remember which one. It's one of the diagrams.
This one?
No.
This one?
Maybe it's that one. So I'm actually okay with your first fear, which is agility. I think that's a basic willingness and fortitude to fix that one. I want you to talk about, we talked earlier this afternoon, but there's a lot of friction in that picture, and also the prior one. Just pure BS friction. So talk to us about, in order to build that decouple layer and to get those system sources, it's like walking through the mud. So
Imran, is it like walking through the mud to combine all these data sources?
So Yeah. So you guys are smart. So I'm looking at, so I'm like, and I don't want to be the one that's contributing to the mud. So, what's your thought? Talk to us about how to get the friction out, because I think that's the piece that can slow us down more than the culture. But feel free to.
So there's
disagree.
two kinds of friction you're talking about. One is data integration, core system data integration. There is not a healthcare legacy system today that is in a standardized, well-mapped, cleansed data environment that can easily be mapped to FHIR. And so part of that is we have to take the friction out for our customers, and we have to create the data mappers that convert 100% of data to FHIR. So we do that with everything from X12 and EDI all the way down to CSV files from our employers, right? Or worse, the hand-entered Excel files from the benefits team at the employer who's not big enough to actually get the attention of their payroll system. So all of the data that's coming in from a friction perspective has to be mapped, cleansed, normalized, tagged, and put onto a FHIR server. And as you know, FHIR servers have not been around that long. FHIR endpoints are not that mature. We are taking a risk by getting ahead of the market and creating endpoints that don't exist, where there is no implementation guide, knowing that when an implementation guide is created that we're going to have to go back and redo that. And so we're basically knowingly creating technology debt. Imran earmuffs. He knows it though. When you think about friction of applications and point solutions, there is zero question that we have to create comprehensive consumer workflows where the consumer doesn't care how many connections are in the back end. The consumer friction has to be removed, and that means that apps are going to have to work within apps. This is a newer kind of technology that historically has been done through iframes, very clunky, SSOs, not ideal.
Sorry.
Yes, portals. But thanks for making that face when you said it. It made me happy. We are now moving into a world of headless applications and who really controls the user interface. I think the big stakeholders are going to demand they have access to data and microservices components that can be plugged into the infrastructures and architectures they have. One of the friction points that we've learned is that we can go into any large payer, any large pharmacy, any large anything in healthcare, and what they're going to say is we have an app, or in some big payers' cases, 7 of them. None of them are actually delivering on the promise or the commitment or the results that they need. They're not inspiring loyalty. It's much like health systems like to tout that they have, 60% of people enrolled on their patient portal. And I'm like, yeah, but how many of them ever return? And that number drops to less than 2%. But that's not the number they're putting in the market, right? So we don't have the loyalty and stickiness because we're still highly fragmented. So the microservices components allow you to not have to give up those apps. Why do big stakeholders not want to give up apps? We're going to make this an open dialogue. Why do they not want to give up the apps they have? Number one reason. Brand. Not data control, not brand. Already registered users. If you have an application, whether it works for you or it doesn't, and you have 3 or 4 million people registered on it, you're not going to throw it away and tell them to go download a new application and start over. So microservices components become really important because you need the capability of things like, there's not apps out there largely in payer, employer systems and others that are hybrid applications that say, I'm going to import the patient right of access. I'm going to give consumers and their families the right to import all their data, show them their data, educate them, give them consent to share it. It doesn't exist. They don't have advanced architectures with APIs that allow apps to onboard themselves. They don't have personalized N-of-1 communications, and most of them, I've not seen one yet, has appropriate consent management. So when you think about those core things, there are things that every application, I don't care who you are in healthcare, need because you don't have them today. But how do you not give up the 7 million, 8 million, or 80 million users that are on the platform? You have to find a way to work inside of other apps, and that's where microservices components comes in. Imran would be happy to describe it for you, but he's already in sidebar conversation. So
I have to be honest.
Be honest.
I thought you were going to include regulation in part of your challenges.
I'm a regulatory nerd, and things have to be regulated to get done around here.
And you're not afraid of the current pace and the regulations that have been put out by the ONC to support?
Hell no, I want them to go faster.
Right. Aren't you concerned that the EHR-based outbound-only use cases that the ONC is putting forward, isn't that a concern to holding you back?
I don't think so, no.
Okay.
Because if you think about ONC, HHS, and CMS, first of all, are open about the fact...
No, CMS is doing awesome.
CMS is doing great. I hands down, they've outwardly said, we're creating a shoppable healthcare consumer.
Absolutely.
No question about it. You're going to have price transparency, directory transparency. They're going to keep pushing the APIs
Love
forward. Much better, for sure. When you look at the big economic picture of healthcare, we are in an absolutely unsustainable model. The only power, and ONC and CMS have been pretty clear about this, HHS less so, is that the only way that we are actually going to bring down the cost curve is to get the consumer more involved and put the consumer in charge. So the shift to moving and forcing people into value-based care has been very slow. Well, it needs to accelerate. That's why they launched, and CMS is kind of setting the example here, direct contracting entities. I don't just want consumers to be able to collect, aggregate, and direct their data. I want them to direct their premium dollar at risk. So it's a way of putting 100% of Medicare beneficiaries into a risk-based contract. Only part of the risk now is on the MA side, and the other part is on the provider. Well, providers now have to play in the margin. They have to figure out how to actually keep people healthy outside the four walls of their hospitals. That's why you're starting to see virtual care models emerge. Primary care is about to enter the Hunger Games phase of healthcare, right? There's going to be an outright battle for primary care. Why? Why are all pharmacies investing in primary care? Village MD, CVS and Aetna just put primary care, right? Walmart was going to disrupt insurance, and they were going to put a $10 visit in their big box stores because they were going to lock down the social determinant codes. Because when you go in for your doctor for $10, you can also pick up your groceries, which they were going to have Medicare pay for, right? So there's a lot of different monetization models, but primary care is really important because 90% of value-based care risk models, and I don't care if it is Medicare Advantage, an ACO, or whatever you might call it, they are HEDIS measures. People, we are closing evidence-based medicine gaps in care, no matter what you call those risk programs. So being able to get the user to be loyal to you is how you're going to actually start to play in the model and earn the money.
And my point was substance abuse.
Yes.
Talk about how we have to support better granularity on consent models. We have to be able to do that.
Absolutely.
But in the face of that, you have the ONC and TEFCA and the RCE stating clearly in their final rule that opt-in, opt-out is the only level we're going to support. Mm-hmm. What's your opinion of that? And does BeWell have an opinion?
Yeah, absolutely. Opt-in, opt-out is not the battle to be won. It's patient-level consent on the way that they want to be communicated with and at what level of detail. The government's not going to get involved in that. They're going to say, listen, if you can gather consent, which we do, and we actually go as far as collecting signatory authority from that consumer, because we don't want it to be and we create best practices because you don't want it to be a click-through, right? The way that we got early access from a connectivity perspective to Medicare fee-for-service, the Veterans Administration, we got to go first because we were able to put and get responses back that said that is hands down the best consumer experience at a 4th grade reading level with informed consent that we've ever seen. It's trust, right? Now remember that the federal regulations don't actually mandate that the application consumers are choosing needs to be a good actor. As long as you state very clearly in your terms of service and privacy policies that you're selling data, you can sell data all damn day long, right? But it's up to the consumer to trust, and they're basically saying, but no one in healthcare gets the paternalistic right to say that you can't. If a consumer says, I want to sell my data, there's going to be applications that say, hey, match me to clinical trials. If you give me $5 every time you share my data with a pharma company, that's an income stream for me, friend. That's right, and consumer trumps regulation. Think about, and the precedent was set with commercial contracts, right? If even in Medicare, if you're a private Medicare Advantage plan and you have a contract one-on-one with a system or a provider, the federal government will not get involved in any dispute in that contract because the contract trumps the federal legislation. Consumer authorization is key. And so how we engage with consumers to drive trust and loyalty and gather that consent is going to be the war that wins loyalty.
But the ONC and TEFCA is trying to drive these QHINs and quality-based networks, and so you're going to have to interact potentially with these QHINs.
It does. So, all right, let's jump on a soapbox, right? HIEs and HINs, right? We've been pushing and running towards FHIR access and trying to create APIs that are tethered to portals, right? OAuth, it's tethered to a portal, portalitis. Something that we really have to get away from because we know that when consumers say, I want my data, when you drop them into a login and password that they don't have, 70% of those people abandon ship. They're not getting their data. They're leaving. And so the misrepresentation by the market of consumers don't want their data is actually fabricated because consumers can't get their data. Because they call the office and they say, oh, no, you got to have an in-person appointment. I can't give you that token or credential unless you're in front of me. information blocker HIPAA violation. It doesn't mean they don't want their data. It means they can't actually drop in and get it. That's why the pinging of the, the connections.
HIPAA
and we don't have
states-
enough applications.
HIPAA states I, as a provider, can't give you, the patient, the data. HIPAA says that. I've heard them say that.
Tomorrow, you and I are going to go toe-to-toe on HIPAA, friend.
I know the difference, but, I'm telling you.
we don't have enough time here, right? But let's talk HIEs and HINs. What's the most important part about a health information network to patient-level data exchange? They don't have a portal. You can't drop them into OAuth. So that's where digital identity verification comes in. NIST and IL2 level certified identity management. And believe me, friends, I firmly believe that in the next 10 years, your facial biometric is going to be part of your medical record. We are going to be using biometrics to log into things. It's very secure. We don't want to do known information. You can gather that on Facebook. We also, yes. So the reality is that when we think about HIEs and HINs, if you can do digital verification to prove that the person is who they say they are, and if you can do probability-based matching out to those networks, and you can say, I'm going to ping for these 10 providers. In my daughter's case, these 17 providers. She never has to have a portal or maintain one with one of those 17 docs. And that, my friends, is where I think the HINs and HIEs have a very new value proposition. So of course, QHINs are going to emerge, right? And there are folks that are not even going to actually go and get QHIN certification, that are just going to be special purpose health information networks. Why? Because no application developer wants to go connect to every provider, every payer, every wearable and sensor, every pharmacy, and everyone we're going to have to do app implementation onboarding with. It's too hard. You don't have to have the legal relationship that slows it down, but you still have to go through a different app implementation onboarding process with every person that you connect to. So that if you think about the aggregator of networks, if someone can be the hub to a spoke model and build the infrastructure and say, hey, HIE1, HIN2, HIN3, you pay me, and you don't have to do app implementation onboarding. I'm going to fulfill 100% of your patient right of access requests, and I'm going to do app implementation onboarding for every app that wants access to everyone within that network. It's a hub and spoke model. It makes it easier for the app developers. It makes a business model for HINs.
Don't use the word hub. Connector is good. The word hub is bad.
Okay, hub is bad. Team, you hear that? Connector. Check.
But if I can chime in and
Yes.
support where you're going, if you look at the fire at scale work we're doing, what that hopefully will lead to is a whole bunch of enablement of trust networks across the country. I hope there's not 5,000 of them. I hope there's a reasonable number.
I agree.
And the ability to hop fire transactions between them, because not everybody has the ability to go point to point. So I think it supports what you're saying. If we can get those stood up, and those groups of entities can trust each other, then it makes the bottom part of that picture easier.
I agree.
That's where we're trying to head.
Yeah.
Because 400,000 point-to-point API interfaces is silly.
Well, if you think about it, those point-to-point interfaces are going to get bigger. So let's talk about real-time pharmacy benefit check. Now you have all the PBMs. PBMs aren't even in the equation today. So I would like to go to the people who move that data. Hey, SureScripts, you actually have the data and the network already stood up against the PBMs. Why don't you have them contract you to provide patient right of access requests on real-time pharmacy benefit? There's so many of these opportunities.
Hence, another trust network.
And another trust record. Then we get into federated identity against trust networks. So there's a lot of debate and conversation around how, because there is no certifying agent for an application.
And I'll bet you this outruns TEFCA trying to become FHIR. It's just going to happen.
That is a bet we will continue to explore every time we meet from here on out. I'm not taking that bet, by the way. I'm just going to check in on it because I think it's a worthwhile comment. For sure. All right, friends, any other questions? Yeah?
Do you think SureScripts would ever do what you just said?
Yeah. I do actually. I think it's a smart business model for them because it's revenue that they don't have today. They've already built the network in place, and they can start to, much like the EMRs, they can start to earn revenue on the fact that they can maintain APIs. So one of the first things that EMRs did with systems when we accessed their EMRs and FHIR APIs went live is they started charging a fee to those health systems. Remember, they're already paying for the EMR, they're already paying for the portal, they're paying for their data, and now they have to pay to maintain the APIs because the applications cannot be charged directly. So no one loses revenue in healthcare. You just find a different way to turn it on. And so SureScripts is going to figure out that even though the PBMs aren't going to love it, that they have a unique opportunity to provide a business model with a new revenue stream that they didn't have before by maintaining those patient access requests. It's the same thing with organizations like a MasterCard. HSA and FSA data, not regulated or mandated, but it's coming. And when it does come, they already have the transaction flow of 85% of the data for HSAs and FSAs because they own the card business, but they don't view themselves as owning the data. And so same thing as SureScripts. Yes. But why would every PBM want to go create an app onboarding process and workflow that they have to do independently, set up a FHIR-based API for real-time pharmacy benefit check when SureScripts can do it once on behalf of all the PBMs and they get economies of scale? We have a naysayer over there. Tell me, what's your hesitation? But that's why, right? It's a new business model. Listen, all of the monetization is going to happen now with all these transactions on these API feeds. You want to figure out where margins start getting added back into healthcare, it's going to be on volume transaction. If you look at every other part of our economy, kind of as was said earlier, pre and post internet, right? We went from having to pay multiple transactions for data feeds and network fees and things, and then you started realizing that you could become preferred, right? So now people are going to start to bundle transactions, and then they're going to naturally turn into SaaS model and different kinds of tiers. It's not going to be a per transaction fee. So then they're going to say, if you do so many transactions with us, then we're going to lower that cost or that fee. It's happened in every other part of our economy. Why wouldn't it happen in healthcare? We're just behind, but we're not actually looking forward at what the business models started as, evolved to, and eventually landed at. And we're literally trying to recreate the same thing here in health. I mean, the banking system is a good example. Travel is another good example. Similar things that have happened in terms of data liberation pre and post internet, picking up the phone to post internet live transactions. All right, we're done, friends. Thank you for staying so late in the day. Very much appreciated it. May you get a cocktail and enjoy your evening.
I believe Melanie has a class.
Yeah, director. I want to explain how important director is. It's don't have to. No, but wait, there's a point you're missing.
I'm a new mobility program manager, and